I have 2 o'clock by my time, so welcome everybody to the Provincial Practice Facilitator Network webinar for May 3rd. We will get started now. If you want to go to the next slide, please. Thanks. Just our treaty acknowledgement. We would like to recognize that we are webcasting from and to many different parts of Alberta today. The province of Alberta is located on Treaty 6, Treaty 7, and Treaty 8 territory, and is a traditional meeting ground and home for many Indigenous peoples. Just a disclaimer that this webinar is being recorded for quality and training purposes. It will be posted on a secure ACT collaborative site for the purpose of sharing and learning. By participating in this session, participants understand and consent to the recording being made available to those who have access to the website, and it could be there for an undetermined amount of time. So today's webinar is all about patient medical home in the health neighborhood. So we are going to talk about social determinant of health today, and we have a few different practice facilitators going to talk to us about their experience over RIFS over the last year and a half. And Amit and myself are going to share the moderating part of this presentation today. And I think on Jill too, sorry. So with the little annotate and your text, I'd like to hear from everybody. What do you think when you hear social determinant of health? What comes to mind for everybody? Social economics. There's partially up.
Charlotte, I'll jump into. I really like that compassion piece. I think that's really core to me when I think of the social determinants of health. So thanks to whoever wrote that one.
And I'm getting, is everybody else just getting partial comments?
Yeah, we might have to do some interpreting here, eh?
Yeah. I'm trying to think if it's understanding compassion. Income class.
Postal codes, that's a really interesting one.
Yeah.
Esther put in the chat finances, so income and finances going hand in hand there.
Struggles, challenges with eating ends meet. Yeah. I'm not sure what's happening too, so maybe some people, trying to add adverse. There's a lot coming up.
I think Tara
adverse childhood experiences.
Yeah. I had a professor that was a big proponent of adverse childhood experiences as a determinant of health. So.
Oh, perfect. Yeah. Rhonda says, fixing little things helps so much for health, access, support, room to breathe. Education and literacy. Yeah, we're having a few of the comments cut off. Sorry, guys.
It's all right. The chat works well as well. We've got things that impact our quality of life. Yeah. I know we've got a couple definitions as well. I think these are really great. I know the one that really sticks to me is like the WHO definition. Really like anything that influences like non-medical factors that influence health factors or health outcomes. So, you know, whatever condition people are like, I think it's grow, work, live, born, age, really any of those factors and those things that impact their daily life. So really all encompassing.
Oh, we're getting some echoing. Okay. Oh, so can we erase? There we go. So this is a slide that Natasha actually had as part of her presentation, but she's going to talk to us a little bit more after we're done this slide. So what makes people sick? So we know that 50% is life, 25 is health care, 15 biology, and 10% is environment. So has everybody seen this slide before? And or is this something new to people? Great, first time seeing, awesome. So this slide is actually available on the ACT collaborative site, and there's actually a whole area now available with videos and information about reducing the impact of financial strain. If you want to learn more after this webinar, I would encourage you to look there. And so we'll go on to the next slide, please. Oh, so there we go. We're going to watch a little video here. This video is called "What is Helpful Help?" And Joanne was part of our project in Kelowna Country. She was one of our community people that was helping us to kind of bring everybody together to work as a bigger community. And we had a poverty simulation day when we first started the RIFS project. And so we're going to listen to Joanne's story, sorry.
I was the director of a family and community support service for 16 years. Occasionally, I was asked to sit down with frequent users of the food bank to see if there was any additional funding they could access or places they could cut back on spending. It was a simple request, and early on in my career, I thought that the answers would be simple. Stop drinking and smoking, get rid of your large pets, get a better job, and start making better financial decisions. I learned very quickly financial strain is a complex issue. We seldom found an easy solution to any of their difficulties. I realized that smoking and drinking were often coping mechanisms for trauma experienced in their life. Pets often took the place of human contact and nurturing, providing the unconditional love that people were missing. Some people just didn't have all the good health or skills and abilities necessary to get a higher paying job, or any job at all. Even if opportunities were there. I remember most people saying to me in those conversations, "How do I budget better when I have no money to start with?" Our visit would usually end with me phoning the food bank and giving the go-ahead for them to have another food hamper. I often wondered, if there was no helpful help I could provide, why even have these uncomfortable conversations? Years later, in my new position as an AHS Community Health Promotion Facilitator, I received a phone call one morning from my manager about a pilot project called Reducing the Impact of Financial Strain. I was excited to get involved. The project goal of having healthcare providers screening patients for financial strain just made sense to me. I knew it would have great impact if we could pull it off. One of the first projects we did as a team was a poverty simulation in order to build understanding of what it was like to live with financial strain. I was a single parent of 2 children with a grandparent in the household. Each family was given a unique package that provided them with weekly tasks, a month's worth of money, bills to be paid, and items to be pawned if needed. The goal was to get through the month without running out of money. It seemed like there was just not enough time to get everything done. As a father, I felt guilty that my children didn't take part in after-school activities because they had to work or babysit. I forgot to purchase enough transportation coupons for all our family activities. We spent so much time just trying to access what we needed to get by that there was no time to improve our situation. I don't think any of us expected it to be such a powerful experience. After years of having these conversations with others, I had a much deeper understanding of their daily reality. Many of us commented about how it was so exhausting to live with financial strain, and we only did it for an afternoon. Together we realized how difficult it was to think about healthy living when all we could focus on was getting through the next week. And the conversation shifted to how the best healthcare in the world would not help us when we were living in financial strain. As communities, we can ask the questions, listen to the stories, understand each other, and learn to provide helpful help that supports us all to live healthier lives.
Okay. Oh, here we go. Perfect. So our first guest speaker is Natasha Hallett, and she's from Kelowna Country Primary Care Network, and she was our practice facilitator for the project and also our community liaison. And so I'd like to turn it over to Natasha.
Yes, thank you, Charlotte. I really appreciate being here. And I know I only have a few minutes, but I think this is something that we can talk about for hours and hours. And it is so relevant in our clinics for sure. Thank you. I can have the next slide. Perfect. So we were honored enough to be part of the RIFS project, or it stands for Reducing the Impact of Financial Strain. And we were one of 3 pilot sites with McLeod River and St. Albert Sturgeon. And our task was, in the beginning, the only direction we had was we had to implement a screening tool for financial strain. And so we had to kind of navigate through all the different scenarios and situations. And we were trying to help and make a change package for screening for financial strain in the primary clinic. And we were able to, with the other sites, of course, EMR guides and help with some evaluation information. And like Charlotte said, all of this would be on the ACT website, albertadoctors.org. Thank you. You can do the next slide for me. So I think the thing that we really struggled when we started to implement this was people always ask, is this actually part of primary care? Like, why are we screening? This is social workers' job. The physicians are, I have only 5 minutes with my patients. This is not part of my job. And so I think it's really important that we go back to the statistics, and what is shown is that 3 million Canadians live in poverty, and about 150,000 of those are children. And there's so many people at risk as single parents, recent immigrants. So you are bound to see these patients in your clinic. So yes, you can do the next slide. So, and as we know, there was a recent study done, and this was after COVID and the impact of COVID, and about 61% of Canadians said that they are worried about their finances. So again, this is something you're going to see with the majority of your patients you're seeing in your clinic. Thank you. Next slide. So again, oh, sorry, I thought someone had maybe a question. So when we got this task, we really didn't even know where do we start. So we had to go back to everything that we learned as practice facilitators. And so we got, obviously with the wonderful guidance of our AMA facilitators, we got to the sequence to achieve change. So we really had to go through all of these steps and really implement each of these steps to be able to do the screening tool. And I know the others will be talking more about specific steps in this tool, but I think one thing that we found that was really essential was to really celebrate the small changes. And I can't say celebrate enough, because it was a big task to kind of implement these screening tools in the clinic. And I was honored enough to work with 2 teams. Each team had their own different challenges. And so you really have to celebrate those really small changes and kind of work towards the next step. So what can we do differently in the next PDSA? We celebrate. How can we do the next PDSA? Thank you. You can do the next slide. And as I said, we also helped in making the change package. So it's really helpful to look at the change package. It is on the ACT website, and when you presented with a task, it's really hard to kind of think through it, but the change package is your tool that you're going back to. Okay, so we did that PDSA, what next, what can we do differently? So really going back to this change package can help you identify those different tasks that you can really focus on. And yes, so this again is the second page of the change package. I'm not going to go in much detail because, as I said, it is on the ACT website. And I know most of the practice facilitators have seen the change package before, and it's the same one, like it was used with the opioid and a lot of the other work that you guys have done. So yes. I just wanted to leave like a minute if there was any questions. I know I kind of ran through everything, and there's 2 more presenters that will be talking about the RIFS project. But if there was any questions for me so far.
I don't see anything in the chat box, Natasha, like that, but people will be able to add things as we go along, so you can maybe watch.
Yes, for sure. Like add them in the chat. I'll be more than happy to answer them. And then I know they will be providing you with my information too. Like if anyone has any questions, I think something that really helps is to go to someone that have done this work before, and to have that kind of mentor that's able to work through the maybe not a crisis, but the challenges that you might be presenting with as you go through your change package and your sequence to achieve change. So yes, please reach out.
Okay, so the next slide. So we're going to do a breakout room, and we're going to show you some more videos of the different ones that were made during the 1.5 years that we.
I'm going to share my screen again. Can everyone see that okay? It says breakout, hopefully.
Yeah.
Awesome. Okay. So our next, we were going to do a bit of a annotate activity reflecting on the RIFS videos. And I know everybody didn't quite get finished, but did you have any reflections, at least for the first part of your video, or anything you wanted to share with the group that, you know, that the video made you think of, or any thoughts?
Yeah. Looks like someone's got there that they see patients like Mark, I presume, in their practice. Definitely. I think going back to like the stats that Natasha shared, right? Like I'm sure that I'm sure we all see patients like that. So thank you for that. Even $10 can be quite a big deal. Empathy is needed. Finances play a huge role. Very impactful.
I think one of the other things that comes to mind is that we all probably know somebody that's in our family, or you know, maybe we've gone through a bit of a financial strain at some point in our own lives.
I think it speaks also to that vulnerability that patients need to go to admit that they're having these kinds of problems. And it, you know, as it was mentioned in a previous slide, it can affect, you know, it doesn't discriminate based on anything. It could be happening to anyone, and anybody could present in any way and still be struggling financially. So the, you know, in the video we were watching, the person went back and said, wait, could you elaborate a little more on what half out of necessity means? And so I think just working some of those questions in and not just, you know, making those assumptions that everyone has equal access, you know, and that they may not come back and admit, I couldn't do my homework because I couldn't afford to go to the grocery store. Like, you know, I couldn't afford to refill my prescription. I couldn't afford to take the bus to wherever I needed to go. It's sometimes hard. It's easier to just no show to the appointment, right?
Yeah.
Sure.
Yeah, that's very
Thanks, Erin.
profound.
It's always nice, important for us to realize that so many of these social determinants can ebb and flow so quickly and so easily, and one can have such a ripple effect on the rest, where somebody might be working part-time, and then their hours get cut, and then that affects their medication coverage, and then that impacts their financial strain even more, and then that can ripple to their transportation and their food insecurity. It's just, yeah, it's such an important thing to understand.
Yeah.
So Michelle said, it made me think how often we're not taking action to help early enough. Prevention versus reaction.
Yeah, it's that notion of like, why are people drowning in the first place? Like, what's the thing that's pushing people into the water? And we're spending a lot of time pulling people out, but what's going on upstream, right? I know Kate here has got considering the pyramid of health, and we've got a comment here as well about the multiple layers in solving these issues, those physiological needs perhaps at the very foundation of the pyramid, and the importance of addressing those. So thanks so much for the reflections. I hope you're able to go in and watch some of those videos. They are very powerful and very profound. So I know Angele's put in the link to the videos there, and so yeah, even like a great team building activity, I find. So watching a video or two together as a team and discussing it might be really a good experience, I would say. So I think with that, we'll move on to Lacey from McLeod River, and she's hopefully going to share some of her experiences. So Lacey, I'll hand it over to you.
Thanks so much, Ahmed. Yeah, so I'm Lacey. I'm with the McLeod River Primary Care Network, and I'm stationed at the Life Medical Clinic, and we were one of the 3 sites involved in the RIFS project. As Natasha went through, she said that we were working through our change package. Go ahead, I can have the next slide, please. Yeah, great. And so we were tasked with the job of creating a social determinants of health screening tool. There really wasn't a lot to work off of. This was new and an innovative project in the province. And we only knew that if we were going to change a process and implement a screening tool, we wanted to ask more than one thing. The sample screening tool, I think if it came from Ontario, it asked just one question, and it was in regards to financial strain. And we already had a population in mind that we wanted to roll this out to, because we already knew our vulnerable population from previous change packages and pilot projects that we had been involved with the AMA. And we knew we wanted to dig a little bit deeper. Were they having financial strain, and where did this ripple to? Was it transportation, medication, housing, social isolation, and social support? So those were the 6 things that our screening tool really wanted to divulge into. And then we thought that would give us a bigger picture of where maybe we needed to focus our community supports, or where we needed to build a few more pathways. We were just really hungry for information around this population. Initially, you can go ahead to the next slide. Initially, when we seen how our processes worked at our clinical level, I know this is a really busy slide, but it's just to be used as a visual representation. The light green, the blue, was all of our physician-led activities. So you can go to the next slide. As you can see, they were involved in quite a few aspects. And we just knew, if it's a physician-led process, or if it's a physician-heavy process, it's not usually something that is sustainable. We know that physicians have a lot on their plate, and let's keep them dealing with only what they can deal with. So when we were working through how to implement the screening tool, we're like, who can we leverage? And it came out to be the MOAs. They would introduce the screening tool, give a slight introduction. They'd say, feel completely comfortable to complete this. This will be kept confidential between you and your physician. And then when the physician would come in the clinic, they would, or come into the room, they would look at the screening tool, see if there was any positive screens, get the patient's consent to be referred to our wellness program. And if they refuse, totally fine. They were able to, in a very comfortable and dynamic setting. Obviously, we really kept the screening tool to patients that we knew. If it was their first visit with that physician, we weren't screening them, right away. We would kind of create the space about what's important to you, how is your health being affected, and then we would always, a kind of a flag would go up if we were talking about the same types of issues at each visit. So you can see as we work through our processes, there's very few physician-led action items, and we really diversified the workload across our team. The next slide, please. Great. So when I was talking about our target population, we had did a gap analysis of our community when we were working through our patients collaborating with teams. And this population, females aged 18 to 34 and 50 to 69, specifically with mental health conditions, we knew that they were accessing health services. So that's outpatients, clinic, emergency, inpatients, all of our health services within our community 4 times as much as diabetes, hypertension, COPD, and high cholesterol combined cumulatively. So it was a no-brainer that this was our population that were really struggling. Well, then of course, then we start to break it down, females, and then if you add, children or single moms on top of that, well, of course, they're being impacted this way. So these were our, we called them walking wounded. If they came into the clinic, we offered them the screening tool opportunistically. We did a few outreach calls. Unfortunately, this is kind of a really vulnerable conversation to have over the phone. Then we wanted to create this safe space. So we leveraged our patient representatives. We had a really engaged QI team where we said, hey, how can we talk about these difficult subjects in a safe place and in a safe situation, and just create the space for this conversation? And how can we do it in a way that won't create more boundary or barriers? I can have the next slide, please. So as you can see, as we started implementing this screening, the results were astounding. We screened hundreds of patients to date now, and at the time when these statistics were pulled, our highest positive was financial strain. And then we can see that it was spreading into, ability to afford medications, transportation to their medical appointments. Housing was a big issue. We know that in our community, housing, and especially with COVID, our subsidized housing really got put on a hold, and as many other communities as well. But the big one during COVID and the impact that COVID was, we've seen a sharp spike in our social isolation and loneliness. So, when we're looking at where to provide supports and what can we do, we're always looking back to these. How can we impact these social determinants? How can we impact this type of strain? I'll have the next slide, please. Great. Yeah. So what worked? What do we continue to use? This has been working well. Creates the space. How do you, when somebody comes in to talk about, a toenail or, something that's really unrelated, how do we create that opportunity to talk about financial strain and the types of things that will impact a patient goal setting and reaching those goals about their health? Can I have the next slide, please? Great. So we also knew that we needed some more connections in our community. Who's out there? What can we offer? We knew the ones that we used all the time, but what about the other ones? We worked really well with Tara Baker, our wellness support worker in the community, and Roberta. They're just our wellness team, and they came up with this community resource board. Unfortunately, this resource board is in Tara's office, and she would send me pictures, and I'd have a big package, and we tried it on a book, and we tried it, blowing it up so I could kind of find it in a library. Can I have the next slide, please? But we knew that this worked so well that we need to spread it across our community. So we documented it in our EMR. You can have the next slide. We promoted that community mapping, and you can see here on the right the picture of the key rings. Oh, sorry. That was our last. Sorry, that's the timer telling me I'm talking too long. That was our, I think it was our 4th PDSA on how to share information across our community resources. These key rings are alphabetized to the main items of support in our community. As you can see, I have them right beside my desk. I use them every single day. They have our food banks. They're organized into clothing, housing, and food topics. And then they have our community resources listed underneath it. And they were created in such a way that they would be sustainable. So they're not just one specific representative. They're like the central office, which would be a continuum, because we did find that was a barrier with, especially with COVID. Lots of FTEs and positions, they kind of emulsified away. So we tried to keep it really, really centralized and on resources that would be there and stand the test of time. We also developed this with community partners. So this would be something that we could renew every few years or whenever we decided we needed to, or if new resources came into play. But as soon as we found that we were using this and giving these resources to the patients that we found in need, they were at least connected. If they called anybody on this list, we could connect them to the other partners. And then, we just would respond collectively as a team, especially after, we see them in the clinic and we're like, hey, these people are in strain, like they're really struggling. How do we help them? And we kind of knew the pathways. We as clinic staff knew the name of the person on the other end that we needed to call, and we just really mapping out those connections and those relationships has been really helpful. Next slide. I think I should be done. Great.
So lots of people loved your idea there, your cards, and
I don't want to take credit for that one. That was totally terrible. That's why greater minds than mine were on the team.
And yeah, I like that, Erin. Powerful medical neighborhood. There is another question as well, which is from Erica. When you referenced the wellness program, what did that consist of?
So our PCN has a wellness program. It has a social worker and a mental health worker. Well, and then they don't call her a social worker. She's a liaison worker that supports a social worker, and they're just, we call them our community navigators. I don't know how they keep up to date on what they do, but they know everything. If a nickel drops in the street, they know who's there to pick it up and what's going on. And they're just such a great resource. And if I could just clone them and put them into the clinic and, just shovel them in with the patient that's screen positive, that's what I would do. But we knew that if we just created the capacity within the clinic for that knowledge, and we have ideas bouncing around, maybe we need like a central electronic hub in the waiting room where these key rings are electronically on an iPad in like a standing kiosk, or maybe those kiosks need to be at the library or, somewhere really accessible. So we knew that information it couldn't be held within our wellness program. So they've been really great at trying to, knowledge transfer to us.
Absolutely. There is another question. I'm going to hold it until our Q&A afterwards, but I wanted to just ask you, Lacey, am I right in thinking that you guys got t-shirts for your team?
We did. It's call us first or what matters to you, and that was the terminology that was in lots of the test boxes. And it was through our packed work through this RIFS project, and we've really just taken it on as a change in mental state. Dr. Joseph, who's our physician champion here, he lives and breathes by the motto, it's not important just what you do, it's how you do it. It's not just important that you go in and screen the patient. It's how are you doing it? Are you creating a relationship and a connection with them that they feel safe to tell you about it? Because it's one thing if you go in and they don't feel safe to disclose any of that with you. Okay, I've screened them, they're fine, but it's how you do it, creating that connection. What matters to you? What's getting in the way? Let's talk about it.
Yeah, that true patient's medical home, right?
Mm-hmm.
Yeah. Okay, well, I'm going to pass on to Pamela from St. Albert and Sturgeon, but we will come back to the questions that are in the chat when we get to the Q&A.
Okay. Thank you.
Hey, hi, I'm Pam, and I was the CIF for the Reducing Impact of Financial Strain project for St. Albert and Sturgeon Primary Care Network. Our project focused mostly on, well, just focused on the Sturgeon County population. I did see one of the questions was just about what is a liaison, and part of our project funding included a community innovation liaison. And so actually one of our LPNs was seconded into the position, and she worked as essentially like a social navigator for the project, where patients who were experiencing financial strain could be referred to. So that was part of the project. It's not something that we have like continuing on at our PCN. The funding is over now, so we don't have that role anymore. And so I just thought I would talk a little bit about the clinical improvement facilitator role and how we implemented the project. And what I really wanted to highlight was the Plan, Do, Study, and Act, because we did Plan, Do, Study, Act, Plan, Do, Study, Act, Plan, Do, Study, Act. We did about 8 PDSAs before we landed on a sustainable model. And when you think that it was really focused on just one small clinic for us, 8 PDSAs seemed like a lot, but it was what was necessary to find a good model. So as a CIF, I was basically the project manager at the clinical level. I worked really closely with our community innovation liaison and also had so much support from the AMA, which was fabulous. And they also coordinated different activities where we could meet with the other PCNs in the project, which was really nice to debrief what we were doing on and share ideas. So responsible for the workflow design and implementation, the screening tools, helping with the clinician guides or any of those external communication pieces too. And then of course, we were also the point person for the clinic and the PCN clinicians supporting the project. So all those PDSAs and the pandemic, it eventually led us to a nurse-led screening program versus physician-led, which really also reflects what Lacey spoke about, just that physician time versus nurse time. So as a result of the pandemic, our nurses were completing wellness checks with who their physicians had identified as vulnerable patient population. And in those wellness checks, we started to screen for financial strain. So we developed a clinician guide with a workflow for screening patients. We provided the nursing team with a script. And then if patients were found to be struggling with any of those social determinants of health, they could either be offered a physician appointment, which was helpful for the physicians at the time with having less in-house appointments, or if they were eligible, and they could only be eligible if they had a Sturgeon County postal code. And I actually did see someone had mentioned that when the whiteboard was up, just about how SDOH can make you think about postal codes. And this was really true for us because you had to have a Sturgeon County postal code to access this program. But so once we finished screening that initial vulnerable patient panel, we started extending that financial screening to all nurse patient appointments. So it really made good sense for us. Our chronic disease management team and our mental health nursing teams already knew the screening tool. They had been using it in their vulnerable wellness checks. And then, of course, they often have those longer and more frequent appointment with patients. And that can just lead to those greater opportunities to look at that overall health picture. And we really emphasized considering social determinants of health with every patient interaction. And then, of course, because we work within the team-based medical home model, we were still able to share with the physicians what was happening with their patients. We'd always write a referral letter back to let them know where the patient was going or who they were seeing. And then another reason why it really worked for us as a nurse-led project versus a physician-led project was that the nursing team was just more familiar with that medical home neighborhood. They knew what programs were out there, and we especially were familiar with the programs in the St. Albert area. But we used this opportunity to become more familiar with what was available in Sturgeon County. And just we were so impressed with what they have been able to do with limited resources. It was really inspiring to see what type of services they had for their community members. So next slide. So just some of our challenges. So the pilot was focused on rural areas. So despite us being St. Albert and Sturgeon, we only could have Sturgeon County patients in the program. So what we would often refer patients to in St. Albert or Edmonton, we couldn't offer to those people. And that was really frustrating, knowing that there was programs out there, but there wasn't something similar that they could have in their community. And then also that some of the resources were the same. So St. Albert has a food bank and Morinville has a food bank, but the quantity and the diversity of options of food were different, but yet we couldn't, Sturgeon County postal code patients could not access St. Albert's food bank. And then as the nurses really got into the program, they also saw that there's patients from St. Albert who have financial strain and they couldn't access the program. And so that was frustrating. And just that there was this stereotype that perhaps St. Albert people didn't experience that, but of course that's not true. The pandemic definitely threw a wrench into our program. We had two clinics. One clinic pulled out early on, and then a second clinic had to pull out with the pandemic, just because the MOAs couldn't support the screening anymore. Similar to what Lacey said, that was really the model we originally used, was MOAs. We're providing the screener and giving a little bit of coaching to the patients. But then of course that wasn't an option when one of our clinics had laid off 3 of 4 MOAs. They just didn't want them prioritizing their time on that. And then the other one, virtual appointments. Like our physicians all moved to virtual appointments, and those physicians that we had in the program, they just couldn't prioritize those financial strain checks anymore. So we definitely had to pivot the project again and create another PDSA from the pandemic. And then physician and patient engagement. So the physicians would often say that they would tell us that they knew who was experiencing financial strain. And so we would receive some feedback from the MOAs saying that, we were told not to screen them because the physician said that they were okay. But of course, there is those invisible patients who are experiencing financial strain, and that also really helped change our model and focus of the project, is looking for those patients out there who maybe aren't your stereotypical people, and just really reaching out to those people that are the invisible and trying to help them get the services that they need. Physicians also weren't sure, is financial strain screening appropriate in a clinic? They weren't sure. They also really felt that that was a social worker role, and not entirely comfortable discussing that with patients. They also felt that really elongated appointments because it could often open up a can of worms, which was hard for them. And then the other piece was that we had no, our community innovation liaison was central. They weren't in the actual clinic. And so just no warm handoff. And that really limited patient engagement because they didn't know who was calling them. Sometimes they forgot that they consented to a referral to our community innovation liaison, and they were no longer interested. They didn't have a relationship with this person. So a lot of the feedback we got from the physicians was that you really need someone in-house, they felt, to have the program be successful. And then of course, pivoting, really, like, we just had to constantly pivot and change the project to make it work. Like I said, we lost our social worker during the project. We originally started with 2 clinics, then we went down to 1 and then none. So it was a challenge to keep pivoting and keep the momentum of the project going. But the community innovation liaison, Stephanie and I, we worked really hard together, and we managed to run the project for the time, which was fantastic, but it was a lot of pivoting. Next slide, please. So that pivoting, though, also led to some of our greatest successes. It really encouraged Stephanie and I to be creative. We had to really think outside the box, like, how are we going to make this project work? We felt a responsibility to the project funder and our patients. And of course, we had seen some patients that were connected with resources which typically wouldn't have been. And so we just felt a responsibility to kind of keep that project going. It was us kind of promoting and pulling for the project. And so those challenges really led to really great teamwork, and it was really good. And then collaboration and connection. So one of the, well, what we would actually consider our biggest win from the project was our work with the town of Morinville. The town of Morinville did not have a social navigator or a support services navigator. Fort Saskatchewan did, but they weren't able to help Morinville. St. Albert, we were funded for our project, and then the funding was going to end. So we were concerned, how are we going to keep this sustainable? But Morinville ended up, our community partners ended up using our data and actually some of our videos. So we have 3 nurses who participated in those digital stories, and they presented it to the town council and asked for temporary funding for a social navigator position. And that was granted on April 1st, and the position just started within the last week. Which has been great. So it's funded until December 21, and we will see what happens after that. But we're just hoping that the data continues to prove that the position is needed. And like our mental health nurse team and our primary care nurse teams have already referred off to that social navigator. And it's just been so wonderful for them to know that there is that support person out there for their patients. And then finally, financial strain awareness. It really was considered that it was no one's job almost to look after that within our PCN. And so we've really made it now, it's like a competency. If you're a primary care nurse, part of your competency work is looking after all those social determinants of health. So we've been working on that and having lots of discussions. And we had another clinical improvement facilitator come in and facilitate a discussion on how can we best enhance patient care for those experiencing financial strain. So it's just really sparked a conversation and some passion over helping people. And it's just been so timely as people have also been affected because of COVID with their income. And that has opened the door just for nurses to have more conversations, and that's just to have more impactful patient care.
Thanks so much, Pam. That was really, really excellent. And Natasha and Lacey as well. This project has been pretty amazing, and some amazing results have come out of there. So we just wanted to give you about 5 minutes for questions, maybe 4, just because we're getting close to 3 o'clock. Does anyone have any questions? I have one actually in the chat. Did you connect the RIFS program to discharge planning from the hospital? Any of you?
Not at our PCN, because we're not actually connected to any discharge planning, but certainly we are aware of like the home to hospital to home program and keeping that kind of at the forefront of our minds and how maybe we could tie in those 2 pieces together.
Yeah, and same, Pamela. We have that awareness with our, but currently it's just the physicians at this clinic that are doing the RIF screening, and we hope to roll that out as our other, like the other CDM nurse that will hopefully be the practice facilitator at the other clinic. We're just hoping to help knowledge transfer and carry her along as they can work through maybe some processes there. But unfortunately, because now we know our patients who have been screened with RIFs, we annotate it as like they have a flag on their arm. We know who they are. We know who they are in our clinic or when we see them. And so when our physician has a patient admitted, we already work with the social worker on their discharge planning, but we definitely can be doing a better job of it. Yeah.
I think too, this is Sue, that I know one site in Kalina Country, and Natasha could speak to this a little bit as well, is actually incorporating RIF screening into their geriatric assessments or their pre-op assessments, because they're doing their own pre-op work, and knowing who is going to be hard to get out of the hospital beforehand and setting things up even before they go into hospital.
Yes, thank you, Sue. I appreciate that. And I think one of the things is when you start this project, like it was for us, in anyhow, my experience was it was a very negative thing to ask people about their finances. And then once the physicians start to realize what a great impact it has, especially for that patient they've seen time and time again, and they just couldn't figure out why they keep coming back, why their blood sugars are uncontrolled. or why their wound doesn't get any better, etc. They really see the benefit of it. And one of our champion physicians, she was actually like, we need to screen everybody. This is a question that needs to be part of when someone goes to the ER, we need to screen them. And I would, and this kind of where the PDSA comes in, because then I was like, wait, can we please start small? Like, we need to start with just a few patients, because then again, it's that really where, how do we support it? We don't want to ask the question and not be able to support these patients. But yes, definitely, it definitely has a place in the home to hospital and home program for sure.
There's a question in the chat. Do any of you struggle to find physicians to attach patients to within your community? We are finding it hard to attach within our community, and for patients with financial strain, it can be hard to travel.
Yes, within St. Albert, we definitely struggle with that. And part of our business plan for the next 3 years is to build a complex patient attachment clinic just for those patients that we are having a hard time to attach. The idea is that, you know, different physicians would run that clinic every week and they could see those certain patients. But yeah, it's definitely a struggle, and we're, you know, also hoping that Alberta Find a Doc will help. But I think it's also something that we're even proposing perhaps to bring back to our board. Like, we just need more guidance on how do we attach those certain patients.
Great. For sure. Well, I would love to keep chatting, but I think we have to wrap up. So over to you, Ahmed.
Thanks, Angel. Really, really incredible so far. Like what a eye-opening presentation in general. So thank you so much for all your insight. Quickly, with respect to some resources, we want to leave you with something. So on the AMA Act website, we've referenced this quite a bit. There are a lot more detail about RIFS. The videos are there. It's under the Health System Integration tab. Angel just put it into the chat as well. There's a change package. So really great material there. If we go to the next slide, we also wanted to highlight some IHI work on the social determinants of health. It's kind of under the health equity lens. And so there's a lot of really great material, a lot of really profound articles, a really awesome framework, a guide for healthcare organizations as well to address health equity that I went through. That's really eye-opening as well. So lots of great material there as well. And then if we go to the next slide, really bringing it back about how it all connects with the patient's medical home. We've talked about the H2H2H guidelines. We've talked about relational continuity. We've talked about the PDSAs and capacity for improvement, and how it's all really connected to the patient's medical home as well. So really, I think comes back to a lot of the work that we're already doing, and just another tool in our toolbox as well. And then I think we've got one final slide about our next webinar on June 7th, really looking at some questions, your questions answered. So if you have any further questions, I know we had a webinar in December and we were going to be revisiting some of that material, but if there's anything further as well, and then maybe we can also move to the next slide. We've got our discussion board, we've got our email, really stay connected. If there's anything that comes up, reach out to our colleagues, and hopefully we can continue to help and support one another. So it's 3 o'clock on the dot. I think, thank you so much for attending. Really learned a lot today. So really appreciate it. And we'll see you all in June.
Thanks.
Thank you.
Thanks, everyone.
Bye.